Okay, this is in very short that we can try and solve most of the renal tubular disorder questions that they ask. We first look at the serum potassium. If it is elevated, uh, it's obviously hyperkalemia. Usually, any case of acquired hyperkalemia with a normal anion gap metabolic acidosis will mean an RTA type 4. Okay, most common cause being diabetic nephropathy followed by CTID, chronic tubulointerstitial disease. If you have hypokalemia, look at the metabolic disorder. Okay, you can either have metabolic alkalosis or normal anion gap metabolic acidosis. If you have a normal anion gap metabolic acidosis, it is RTA type 1 or 2, because type 4 is associated with hyperkalemia. With hypokalemia, it can either be type 1 or 2, right? Now, if they give a history of, say, something like alkaline urine with a pH of more than 5.5, nephrolithiasis or nephrocalcinosis, that is renal stones, and urine anion gap positive, all of this is pointing towards distal RTA or RTA type 1. If there is no history of kidney stones, and if importantly there is normoglycemic glycosuria, it points towards a proximal RTA, which is RTA type 2, which is much milder. It's mainly seen associated with Fanconi syndrome and a lot of other syndromes. Like we can see from the causes, type 1 and 2 are more inherited causes, whereas type 4 is mainly acquired causes. Now, if this hypokalemia is associated with metabolic alkalosis, it is again more of inherited genetic disorders. You look at the blood pressure of the patient then. These are all usually younger children or adolescents presenting. If you find hypertension in a young patient with hypokalemia and metabolic alkalosis, the diagnosis is Liddle syndrome, which is autosomal dominant. The other two are autosomal recessive. They will have a normal to low BP with metabolic alkalosis. The difference will be that in Gentleman syndrome, there will be hypocalciuria and severe hypomagnesemia, which is leading to hypercalcemia, and maybe they'll give a history of Schwastek sign positive, tetany, etc. That points towards Gentleman syndrome. Whereas in uh, autosomal in Bartter syndrome, you will have hypercalciuria, so there will be increased calcium in the urine, not in the blood, along with mild hypomagnesemia. This is Barter's syndrome. Both Barter's and Gentleman are autosomal recessive disorders. So, based on just the history provided, if we want to keep it very short, then we can always look into why we are having each of these findings. But in very brief, first start with serum potassium. Any cause of acquired hyperkalemia with a normal anion gap metabolic acidosis means it is a RTA type 4. Most common cause being diabetic nephropathy followed by CTID. Then hypokalemia with a normal anion gap metabolic acidosis with alkaline urine, renal stones, urine anion gap positive means distal RTA or RTA type 1. No kidney stones and normoglycemic glycosuria means Fanconi syndrome or proximal RTA, which is RTA type 2. With hypokalemia, if there is metabolic alkalosis and hypertension in a young patient, Liddle syndrome, autosomal dominant. Normal to low BP with hypocalciuria, hypercalcemia, severe hypomagnesemia, Gentleman syndrome. And hypercalciuria and mild hypomagnesemia is Bartter syndrome.